Welcome everyone. The webinar will begin in 2 minutes. For those of you just joining us, the webinar will begin in 1 minute. Okay, so welcome everyone to the Leukemia and Lymphoma Society of Canada's webcast, What's New in Myelodysplastic Syndromes. In this webcast, Dr. Stubbins will discuss the new and encouraging developments in understanding and treating myelodysplastic syndromes, discuss new information about why people develop MDS, and the evolving role genetic testing is playing in understanding this. He will also outline some novel therapies that are on the horizon for MDS, including targeted and immunotherapies, and how these are poised to improve both quality of life and outcomes. Let me introduce myself. My name is Sonia Muto, and I'm the Community Program Coordinator for the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. The presentation will last approximately 60 minutes and will include a question and answer period at the end. Since there are many of you, we invite you to type your questions and comments in the question box of your Zoom webinar panel throughout the presentation. An LLSC staff member will be monitoring the questions. I will read some of those questions out loud at the end of the presentation during the Q&A period. The conference will also be recorded, so therefore you can listen to it again on our website. Before we begin our main presentation, I would like to share with you our mission and highlight some resources that might be helpful for you or someone that you may know. Next slide, please. So at the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer guidance and support every step of the way. Next slide. We know that the current situation presents many challenges to those affected by blood cancer and their families. The community services managers can help. They are compassionate connectors that can help those affected by blood cancer cope with anxiety and isolation during these times. Please do not hesitate to contact a community services manager in your area. The next slide. We offer a variety of educational resources and support services to those affected by blood cancer. For example, on our website, bloodcancers.ca, you can access free booklets and fact sheets containing information about specific blood cancers, treatments, and practical information. Next slide. We also have a series of easy to follow educational videos on different blood cancers and treatments. Next slide. You can also visit our website, bloodcancers.ca/webcast, to watch all the recordings of our past webcasts and to view the announcements for any of those upcoming webcasts as well. The next slide, please. Subscribe and listen to our podcast series, The Blood Cancer Experience, to learn more about treatments and research, and also to hear stories from people affected by blood cancer. These podcasts are available on Spotify, Apple Podcasts, and anywhere you enjoy listening to your favorite podcasts. Next slide. So our peer support program is a support service that matches people affected by blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by a blood cancer and share similar experiences. Whenever possible, participants and volunteers are matched based on their age, gender, and diagnosis. This can be a really useful program these days to counter the effects of isolation. And so it is now time for me to introduce our speaker today, Dr. Ryan Stubbins. Dr. Stubbins is currently a fellow at BC Cancer Genome Sciences Centre and the Leukemia BMT program of BC. His clinical and research interests are focused on myeloid malignancies, including myelodysplastic syndromes and acute myeloid leukemia. He completed his medical training at the University of Saskatchewan and the University of Alberta, where he also completed a Master of Science in Translational Medicine. He subsequently completed his clinical hematology training at the University of British Columbia. He was awarded the Leukemia and Lymphoma Society of Canada's Clinician Scientist Award to investigate precision medicine approaches to epigenetic therapies in myeloid malignancies. So thank you for being here today, Dr. Stubbins.
Great, and thank you very much for the introduction, and thank you for joining us today. Okay, so, we're going to kind of start with a broad overview of just some information about myelodysplastic syndromes, and in the second half, we'll start talking about some new therapies that are coming up for myelodysplastic syndromes. So, one common question I get asked is how common are myelodysplastic syndromes? So at the moment, about 40,000 people are thought to be currently living with MDS in Canada, and about 3,850 new people are diagnosed every year with MDS in Canada. And this makes up about 17% of the new annual cases of blood cancers in Canada. So it's the third most common blood cancer that's diagnosed in Canada. And relative to other cancers, blood cancers make up about 11% in Canada of the overall cancer burden. So, MDS, while it's not a common cancer, it is one of the most common blood cancers that we do see. Okay. So one common question I get asked by people is, why do people get MDS? Why does this happen? So, to understand that, it's important to understand some of the basics about how blood is made and how the bone marrow works. So in the bone marrow, there are these cells that are called stem cells. And these are special cells because throughout the life, they can regrow. And these are needed to maintain a supply of blood throughout the life, right? And, blood is kind of a unique organ, unlike things like the heart or lungs, where throughout your whole life, it needs to continually regrow and replenish itself. So that's why there are these special cells called stem cells that exist, which can regrow. And the stem cells then do something that we call differentiation, where they become the three kind of main components of the blood. So they can turn into red blood cells, they can turn into platelets, and they can turn into neutrophils. And for anyone that follows their blood counts, this is probably very familiar to them. And so the red blood cells carry oxygen throughout the blood, and then the platelets help the blood clot, and then the neutrophils fight infections. There's other type of white blood cells as well, but the neutrophils are some of the most important ones. So that's how blood normally is formed and how the bone marrow works. So what happens in MDS is some of these early progenitor cells get a mutation in their DNA, and they're damaged for some reason. And what ends up happening is the cells then can't grow properly, and then the bone marrow starts to not be able to produce the blood cells that it needs. And this can cause a reduction in the red blood cells, it can cause a reduction in the platelets, and it can cause reduction in the neutrophils. And everyone is a little bit differently affected in terms of which one of these sort of lines is more affected. And this can cause symptoms. So when the red blood cells go down, people can get symptoms of anemia. So they can feel tired, they can feel short of breath, sometimes they can feel dizzy. When the platelets go down, people can have issues with blood clotting, and they can have issues with easy bruising or bleeding. And when the neutrophils go down, there can be issues with infections. And, can be multiple kinds of infections, sometimes bacterial, sometimes viral infections. So this is kind of the basics about, how MDS happens. And one other important thing to understand about MDS is that it's sort of related to a number of other conditions. And I kind of like to think of it as this spectrum of what we call the myeloid malignancies. And so you can see on the left here, I have a term called clonal hematopoiesis, or CHIP. And so what this refers to is basically, if you look in the blood of people and you do gene sequencing and you do really deep gene sequencing, you can find some of these mutations that we know also occur in MDS, usually at a very low level. But these people who fall into this category also have totally normal blood counts, and their bone marrow looks totally normal. So all there is there's this kind of low-level mutation that's hidden in the blood. And this is actually more common than we would think, and this is something we've only realized over the past few years. And actually, up to 10% of people over the age of 70, you can actually find one of these mutations. So there's kind of this burden of these kind of low-level mutations out there in the population that we're starting to understand. And kind of related to that, next sort of on the spectrum is something that we call low-grade MDS. And this is something where we can find these mutations. We know the DNA is abnormal, but also the bone marrow looks abnormal. And we know it's not producing the right blood cells because we can see the blood counts are not normal. And quite often patients with low-grade MDS, it can go on for very many years. Sometimes they don't have symptoms. We'll talk a little bit more about that later. And kind of next on the spectrum is what we'd call high-grade MDS. And in this situation, we know that there's these mutations that are present. The bone marrow and the blood counts are abnormal, but also we can see that there's these blasts that start appearing in the bone marrow, which are sort of leukemia cells, but they're at a low level. And we know that people with high-grade MDS are at a higher risk of having complications sooner than someone who has a low-grade MDS. And then kind of on the other end of the spectrum is this thing that we'll think about a lot, something called acute leukemia, or AML. And this is when we can find these mutations and the bone marrow starts getting filled up by these leukemia cells called blasts. And eventually they start spilling over into the blood. So, there's quite a wide spectrum here in terms of how fast these things can cause a problem. People with CHIP can go their whole life without having an issue, whereas people with acute leukemia usually need some kind of treatment and management fairly soon. So, what are the underlying things that cause this? What causes these gene mutations? So, in about 5 to 10% of patients, we can find some kind of exposure that can be related to this. Sometimes it's an industrial chemical like benzene. Quite often it's a previous chemotherapy treatment for a different cancer or a radiation treatment for a different cancer. So in about 5 to 10% of patients, we can identify something that we think, a chemical or radiation that caused the DNA damage that made this happen. Another thing that we're starting to understand more now, and this is fairly recent as well, is that in maybe about 5 to 10% of people, this is just kind of an estimate because we don't really know exactly how many, but probably about 5 to 10% MDS can sometimes be inherited, where you actually inherit a genetic vulnerability to developing MDS. And oftentimes people who have this are younger at the age of diagnosis, and quite often they'll describe a family history of multiple members of their family who've had cancers and blood cancers in the past. But in the majority of people, probably about 80%, we never really identify a specific reason that this happened. The biggest risk factors for MDS, the number one is age. As people get older, the risk of this goes up. And that's partly, we think, just because there's, over time with the bone marrow having all these dividing cells, there's just more risk of there being an error when the DNA is replicating, and that can cause these mutations. But there's other risk factors as well that can affect development of MDS. And these can include things like smoking, sometimes conditions that cause chronic inflammation in the body. And there are some specific occupations that are at higher risk of developing MDS. In particular, things like healthcare or agriculture or working with petrochemicals. So, how do we diagnose MDS? So for most people, they are first suspected of having MDS after having an abnormal blood test. Sometimes they have this blood test done because they have some kind of a symptom, maybe they're feeling tired or short of breath. And sometimes, quite often actually, it's completely incidental, or they're having a blood test for another reason, and then they're noted to have abnormal blood counts. And then typically this will lead to a referral to a hematologist or a blood specialist who will arrange a bone marrow biopsy. And so a bone marrow biopsy test is the only test that we have that can sort of definitively diagnose MDS, although we can suspect it based off the blood counts. And then on this bone marrow biopsy, we do a number of different special tests to make the diagnosis, as well as get more details about what the prognosis is. So one of the most important things that we do is, it's a bit old-fashioned, but it's still very important, is just looking under the microscope. So we take the bone marrow, we put some staining on it, and we looked at it under the microscope. And then I'll show you some pictures later as well, just to show you how the cells look in MDS. Another very important test is something that we call cytogenetics or karyotyping. And with this, we look at the chromosomes or the bundles of DNA in the cells. And this can sometimes tell us about the genetic changes that are present in the MDS, which can help us decide on what the prognosis is. And then we also now have some special gene sequencing tests that we do, where we actually go down and look at the individual mutations that are present. This is a very useful tool that can help us decide on prognosis, as well as tell us about what kind of therapies might be effective. So, as I mentioned, looking under the microscope is a very important part of the diagnosis. And so, and in terms of the name myelodysplastic syndrome, the D refers to something that we call dysplasia. And basically what that means is that the cells in the bone marrow don't look normal. So you can see on the left here, this is a normal bone marrow. And you can see that these are kind of early red blood cells, the ones I'm pointing to here. And you can see how they're sort of nice and round, and what we call the nucleus looks quite healthy. And then you can compare that on the right here. When you have a bone marrow with MDS, you can start getting these changes where the nucleus isn't quite as round. It sort of has this kind of lumpy characteristic to it. Sometimes it can have these sort of two separated lobes like this. So basically, one of the most important things to help us make this diagnosis is we look under the microscope and we sort of quantify and characterize what these kind of visual abnormalities are and how many cells have them. So after a diagnosis of MDS is made, the next important decision is, what kind of treatment is going to be pursued. And, one thing I'd always like to emphasize is that it's very important to discuss with your physician what your kind of goals of treatment are, because these goals are going to vary quite a bit depending on both what kind of MDS you have, what the prognosis is, as well as your own situation. What's your general overall health and other factors like that. So the goals of treatment won't be the same for everyone with MDS. Well, there's some common goals for treatments that patients have. One of the most common ones is if you're in a situation where you need blood transfusions, where it's quite common that people with MDS do need blood transfusions. For many people who require those, one major goal is to reduce or eliminate the need for blood transfusions. Of course, we always want to look at improving people's symptoms. In particular, for many people, the anemia symptoms can be quite bothersome. So improving those is important. And of course, it's always important to maintain a good quality of life with these treatments and making sure that we maximize that, as well as two kind of important goals potentially are preventing the transformation of the MDS into an AML, which is a risk that is there, as well as, in some situations, putting the MDS into a remission can be an important goal as well. And so, it's important to recognize that there's many different types of MDS and they're all treated slightly differently. So there really is no kind of one size fits all solution for MDS. I'll outline some of the treatment approaches that we currently take for the three most common types. And so first one I'll talk about here is something that we call MDS with del5q or deletion 5q. And that refers to a special change in the chromosomes that's seen in these patients. This is about 5% of people who are newly diagnosed with MDS. And it's slightly more common in women, and many of these patients end up needing blood transfusions as part of their treatment. You can see here on the right is a picture of a bone marrow sample from a patient with MDS. So this type of MDS is quite unique in that it responds very well to treatment with a pill medication called lenalidomide. And what lenalidomide does is it actually interacts with the immune system, and it helps kind of stimulate the immune system to treat the MDS. About 60% of people will respond to this treatment and be able to come off of transfusions afterwards. For lower risk MDS, so there's many different subtypes within lower risk MDS, and the treatments may vary slightly depending on what subtype, but many of these patients we know will not have problems with their MDS for many years. So quite often, if people don't have any symptoms, and if they're not requiring blood transfusions, quite often we'll choose to monitor rather than embark on any treatment immediately, just because we know that, quite often there can be a long period of time when people don't have a problem with this. So usually in those situations, we will sometimes consider just doing routine blood tests and follow-up. For patients who do have symptoms or who are needing blood transfusions, there's a few different options. In some patients, an injection treatment with a blood-stimulating hormone, something we call erythropoietin, can help. And this is something patients can do on their own at home as well. And it's not something that works for everyone, and there's a special blood test that you usually do beforehand to see if it'll work. So most people tolerate pretty well, although it can cause some issues with high blood pressure, and very rarely there can be blood clots, but it's extremely rare. The other thing is that in some patients with low-risk MDS, we can use immune-suppressing treatments to improve the blood counts, but this usually only works if there's some certain features under the microscope that would suggest it would work. So, this only really apply using the immune-suppressing treatments apply to sort of a small group of MDS patients, but it can be quite effective. And then for higher risk MDS, so we know that in this situation, the MDS may progress faster. So typically, depending on the situation, we will usually treat it a bit more aggressively. And so one of the most important treatments for patients with high risk MDS is something called a hypomethylating agent, which is a type of chemotherapy. And it can be either given as an injection, something called azacitidine, or as an infusion, something called decitabine. In Canada, we pretty much exclusively give the injection form, the azacitidine. Most people tolerate this fairly well also. Some people can have issues with where they get the injection, they can get some irritation and bruising. And some people can have issues with constipation with it as well. And then the other important thing to know is that it doesn't work right away. And oftentimes people will need to be treated with 3 or 4 cycles of this therapy before they show any evidence of a response to it. And this kind of schedule that people get is usually they'll get treated with 1 week on, and then they'll have 3 weeks off, and then they'll repeat that cycle every month. Sometimes it's given continuously for 7 days in a row, and some places will give it for 5 days, take a break for the weekend, and they give it for 2 more days. Both ways are effective. So we know that up front, about 50% of people will respond to this treatment, and it can reduce the need for blood transfusions and does sometimes put the MDS into remission, but it doesn't always. And it has been shown to prolong survival for people with high risk MDS. But at the same time, it's important to recognize that while this is an important treatment, it's not always the right treatment for everyone. And as I mentioned before, it's kind of an individualized decision for every patient between them and their hematologist as well. For some patients with high-risk MDS, if people are in good health and younger, sometimes we'll consider doing something called a stem cell transplant, sometimes combined with a high dose of chemotherapy. And this can sometimes be an effective and appropriate treatment as well. But again, this is not a treatment that necessarily everyone will be appropriate for everyone. And so in this procedure, stem cells will be collected from a donor, and that can usually either be a sibling or an unrelated donor, or sometimes there's alternative donors we can use as well. The patient is then given a treatment with a chemotherapy to prepare the bone marrow for the new stem cells, and then the stem cells are given back to the patient at that point. And so, this is the only treatment that we have that we know that can result in long-term remissions. Because some of these other treatments that I mentioned, things like the azacitidine, they do work, but we know they don't work forever. So, stem cell transplants offer that benefit of potentially offering a long-term remission, but they do carry a lot of risk up front, and not everyone is physically strong enough to be able to tolerate a transplant. So, this can be an important treatment for some patients, but not every patient will necessarily be, strong enough to be able to tolerate it. So one other common question I get asked quite a bit is, what about diet and lifestyle for MDS patients? So this is an important thing to consider as well. And there's many things to think about with this. And so, there's no specific diet that treats MDS, but it is important to make sure you have a diet that can help you build up your strength and immunity. And you can really do that by focusing on a healthy and well-rounded diet, in particular focusing on making sure that you're getting good amount of fruit and vegetables in your diet, as well as enough protein to make sure you maintain your muscle mass. It's also very important to avoid smoking if you can. And if you're going to consume alcohol, make sure it's just a moderate amount, because large amounts of alcohol we do know can suppress the bone marrow. And it's also important to try and maintain your activity level and maintain, a good level of fitness as well. And, this means something different for everyone. So you need to make sure that you do what you feel comfortable with, and as well as listen to your body in terms of what you feel like you can do. So for many patients, this will mean light walks or kind of, regular light physical activity. So, but it's important to do your best to maintain your diet and focus on that, as well as try and be as active as you feel you can. So, one thing that's of course been on everyone's mind quite a bit this year has been COVID-19. This has had major impacts on both patients and providers in the healthcare system. But it's important to remember to still pay attention to your MDS and still pay attention to your medical needs during this time. So it's important to make sure that you're still getting your follow-up, make sure you're still getting your blood tests, as directed by your hematologist. So, it's important to not forget those other aspects of your health. And, MDS patients are immunocompromised, generally speaking, and they probably are at a higher risk of having complications if they do catch COVID-19. So, it's important to be safe and just use common sense with these things. And, vaccination is a very important way to protect yourself from COVID-19. So we do recommend that all patients get a COVID-19 vaccine when it's available to them. So now kind of on to the second part here, what's new in MDS? What are the new treatments that we're seeing? And so, I really do think that we're starting to enter a new era in MDS therapy. And we're starting to see several new treatments that are coming on the horizon for this. And this has been after a period of many years where there really wasn't a whole lot new, but now we're really starting to see some changes. And these advances have really been made possible by significant progress in understanding the biology, as well as the genetics of MDS, as well as related conditions like AML. And we're anticipating and hoping that these advances will both improve the quality of life for MDS patients, as well as hopefully lead to higher remission rates with fewer side effects. So one of the treatments that's the closest to being sort of available is one called Looseceppa. And this is a treatment for patients with lower risk MDS. And it's an infusion treatment that's given to specific kinds of patients with lower risk MDS. So you need to have a specific subtype. And it's a subtype that we call one with ringed sideroblasts, or a mutation in something we call SF3B1. And this was used in a recently published clinical trial in 2020. And about 40% of patients were able to come off blood transfusions with this treatment. So this is currently being evaluated by Health Canada. It's not yet available outside of clinical trials in Canada, but it is FDA approved. So we're anticipating that this should be coming in down the pipeline fairly soon, hopefully. One other treatment for low risk MDS that's a bit earlier on in the pipeline is something called Hematellostat. And so this is an infusion treatment given to patients who require blood transfusions and have failed treatments like erythropoietin. And there's a recently published clinical trial that suggested about 20 to 30% of patients were able to come off blood transfusions with this treatment. So again, this one is a bit earlier in development, so it's not yet approved by Health Canada or the FDA, and it's still in clinical trials, but something to watch out for. One other treatment that's been coming up for AML in particular and starting to come to MDS is a treatment called Venetoclax. And this is also a drug that's given for other types of blood cancers, namely CLL. And this is a pill treatment, and it's given in combination with that azacitidine treatment I mentioned earlier. And it's shown some very promising results in AML, patients who could not get high-dose chemotherapy as their treatment. And so this is currently in clinical trials for high-risk MDS patients. And we have a number of those trials that are opening up in different places across the country. But again, it's not yet FDA or Health Canada approved for MDS. This is something I definitely watch out for because I expect that it may be something that will be potentially important in the treatment of high-risk MDS. Another treatment for high-risk MDS patients that is also in clinical trials are pill medications that inhibit a specific gene mutation called IDH. And these are pill treatments, and they really only work in patients who have that specific mutation. These are generally quite well tolerated and are being investigated in combination with other treatments like azacitidine for AML. But they're also currently looking at clinical trials for high-risk MDS patients with these as well. So, again, something that we're going to be looking at potentially in the near future here. Another treatment that is now starting to roll out in Canada is an oral version of those hypomethylating agent treatments I talked about. So, I mentioned that there's this azacitidine drug and decitabine, which are very important treatments, are commonly used. And at present, they're only given by injection or infusion. So this can be inconvenient and difficult for patients, particularly people who don't live in an urban area or near a cancer center. So quite often, that can be a major barrier to people just coming in and out to get the treatments. So there's currently oral versions of these that are in clinical trials and are currently on the way to being approved. And there's one that was recently Health Canada approved as well for some types of MDS. So, I think in time we're going to start seeing more and more of the oral versions of these treatments rolling out. And I think this is potentially something that can improve the quality of life for MDS patients as well. And one other common question I get asked about is, what about immunotherapy and what about CAR T cells? Because these have gotten a lot of media attention in recent years. You can see there's been a number of headlines, things like the New York Times, the Toronto Star, and what these are is these are treatments that utilize the immune system to attack the cancer. And the CAR T cells in particular are these living drugs where the patient's T cells are taken out, they're genetically modified, and then they're given back, and then they attack the cancer. So, these have become important treatments in lymphoma and some kinds of leukemia, but they're not available for MDS or AML at this point, and they're still in very early phases of development for MDS and AML. So, hopefully someday, but it's still very early days for MDS and AML, though they are important treatments for lymphomas and leukemias at this point. There's other kinds of immunotherapy approaches, though, that are starting to gain traction in MDS. One particular promising one is this, what we call an antibody medication. It's an antibody directed against something called CD47, and it's called magrolimab. And what this targets is there's this CD47 molecule that sits on the outside of the cells. Let's see, here's just an example. And what this normally does is in healthy cells, it kind of talks to the immune system, and in particular, this component of the immune system called the macrophage. And basically says, when the macrophage, the immune system comes along and sees the cell, it says, hey, I'm a healthy cell, don't eat me, because that's kind of what macrophages will do to bacteria or other things. And so, it's an important part of the kind of regulation of the immune system. And cancer cells also utilize this to kind of hide from the immune system and to sort of block the effect of these macrophages. So what this treatment does is it actually blocks the ability of these cancer cells to sort of hide from the immune system, and it allows these macrophages to attack the cancer cells. So this is currently in clinical trials for MDS in combination with that azacitidine drug, but again, not yet Health Canada approved, but I think this is a very promising therapy. So what about the Canadian MDS landscape? So, there's a lot of very important and exciting and innovative research being done in Canada. And we're seeing more and more clinical trials related to MDS and AML Canada, MDS and AML in Canada becoming available. And this is very important in terms of building research capacity in Canada, because it's an important part of improving access to innovative new treatments through clinical trials, as well as also helping us develop better treatments in Canada. And these projects are possible thanks to the generous support of groups like the Leukemia Lymphoma Society of Canada. And really, nonprofit groups like the LLSC are critical to, us being able to carry out these, this mission of improving the quality of life for patients with MDS and AML in Canada. So one particular project I'm working on is called Precision Medicine for MDS with Azacitidine. So, as I mentioned, there's the hypomethylating agent treatments, the azacitidine and decitabine, have been used for many years now in MDS and AML, almost a decade. And like I mentioned, only about 50% of people respond upfront to this therapy, and we know it eventually stops working in everyone. One kind of question that's been sort of in the field for a long time that we haven't been able to answer is, why don't about half of people respond to this upfront? And we haven't been able to identify a way to predict, who's going to respond to this and who won't. And, kind of the question we asked was, what if we could understand why patients don't respond and predict who will? So we've been using an advanced form of gene sequencing to look at what we call the methylation or the gene regulation patterns in some bone marrow samples for patients with azacitidine. And you can see here on the right side, this is just an example photo of these kind of what we call next generation sequencers that we use. And because of some of the new approaches that have been developed, we're able to actually look at the gene patterns in every single cell, which is sort of a new approach that's being developed over the past few years. And this gives us much more detailed information than we were ever able to have previous. And what we found is that when, and in the past, most people, when they've been looking for a specific marker that might predict who will respond to azacitidine, they've normally looked at gene mutations or gene expression changes, and this has really not panned out in the past. So, we've taken an entirely different approach, and what our data suggests is that it's actually the cell type that determines whether patients respond to azacitidine. So basically, if you remember back at the start, how there were those stem cells that get the mutation. And so one thing I didn't show there is that there's actually multiple different types of these kind of stem cells that get mutations. We think it actually may be related to which type of cell gets that mutation. And this suggests that the chance of responding to azacitidine may be something that is determined very early in the development of MDS. So we're currently working on validating this hypothesis, and we're hoping that there's several potential downstream impacts that could improve treatments for patients. We're hoping to develop ways to predict responses to azacitidine. We're hoping this may point towards pathways that drive resistance to azacitidine. And, ultimately down the road, we're hoping that all of this information can help us look at developing new treatment approaches and combination treatments. Okay, so that's the kind of initial part of the webinar. I just want to thank you for attending the webinar, and I want to thank the Leukemia and Lymphoma Society of Canada for their support and their invitation to do this webinar. I also just want to thank everyone whose support has made this possible, including my supervisor, Dr. Ali Carson, and the Carson Lab, the BC Cancer Research Centre, the Leukemia BMT program of BC, as well as the Clinician Investigator program of BC. Okay, I'm happy to take any questions.
Excellent. Thank you so much, Dr. Stubbins, for sharing your expertise and insight with us today. So now it is time for our question and answer period. And if you haven't already done so, be sure to use the question box of your Zoom webinar panel to type your questions, and we will do our best to get to as many questions as possible today. So let's get started. Actually, we have quite a few questions that have come in. So one question is, should MDS patients with intermediate to IPSS risk or 2.0 taking azacitidine injections? Is blood transfusion better than chemo?
Yeah, so, in patients who have, so intermediate to risk MDS, it sort of falls on the higher risk and spectrum of MDS. So quite often we will treat patients with azacitidine, but, the important thing is to remember that this is really an individual decision. And it depends on balancing your own individual risks and benefits and discussion with your hematologist. So there's a lot of factors we take into account with this. The first is how intrusive are the blood transfusions to your lifestyle? What's your kind of overall health, and what are the logistics of you being able to access these treatments? Do you live very far away or problems like that? The important thing to remember is that there are also risks with blood transfusions. And in particular with long-term blood transfusions, we worry about the accumulation of iron in the body, as well as sometimes people can develop some immune problems related to the blood transfusions. But at the same time, there are side effects from the azacitidine also. So, I'd say it's an individualized decision. One isn't necessarily better than the other, but quite often we will use azacitidine in these scenarios.
Thank you. Another question here is, prior to my stem cell transplant, I received full body radiation along with chemo. Is that still necessary?
Yeah, so this is, the kind of what we call the conditioning regimen for MDS transplants is still a bit of a controversial area, and each individual center does things slightly differently, just because each center kind of goes based off what their local kind of experience has been. So, in many places, we will not use radiation for MDS transplants. At least locally in Vancouver, we don't. But that said, there's many institutions that do still incorporate radiation into that treatment. So I'd say it's center dependent, depending on what their local experience has been. So it's not an absolutely necessary part of the conditioning regimen, but it kind of varies depending on, where you get your transplant, basically.
Thank you. What is the main difference between myelofibrosis and myelodysplasia?
Yeah, so this is a really good question. So, myelofibrosis is one of these conditions that's sort of, again, on this spectrum of what I call the myeloid malignancies. And the main difference between MDS and myelofibrosis is that with myelofibrosis, there, in addition to these genetic changes, there's quite a bit of scarring in the bone marrow that we can see when we look under the microscope. And so, this actually results in some different symptoms that we don't usually see in MDS. In particular, people with myelofibrosis can sometimes have issues with big spleens that can be symptomatic. And sometimes they'll have other issues with things like itchiness or other kind of symptoms like night sweats. And normally we don't see those in MDS. So the symptom profile is a bit different. In addition, there's some treatments that work for myelofibrosis that don't work for MDS. In particular, an oral medication called ruxolitinib is a common one used for that, but we don't use that in MDS. So those are the main differences. So the bone marrow looks a bit different, the symptoms are a little bit different, and there's some treatments that we can use in myelofibrosis that we can't in MDS, but they are sort of in the same family of conditions.
Thank you. I have a question here. Speaking of reoccurrence, so what is the likelihood of a reoccurrence of MDS with the treatments, or what is the likelihood of getting a secondary cancer from treatments?
Yeah, so that's a really good question, and the risk of recurrence is, it sort of varies depending on what exact treatment you're looking at. And it will also depend on what the genetics of your MDS is as well. What we do know is with treatments like azacitidine or lenalidomide or those types of therapies, we know that those aren't therapies that will work long term. They do work very effectively, but we do know that eventually the MDS will come back with those treatments. And the only treatment that we have that can sort of result in long-term remissions and sort of, get rid of the MDS is stem cell transplant. And with that one, the risk of it coming back is dependent on a lot of factors. And, specifically the gene mutations that you have play a big role. But, kind of ballpark, most people are somewhere between 20 and 30% risk that it would come back after a stem cell transplant. But, that's kind of, there's a lot of variables that go into that. So it'll be different for every individual person.
Thank you. Is Polycythemia Vera under the MDS umbrella?
Yeah, so Polycythemia Vera doesn't fall under the MDS umbrella, but it does fall under this kind of bigger family of kind of the myeloid malignancies. So Polycythemia Vera is part of what we call the MPNs, or the myeloproliferative neoplasms. And that's also actually the same category that the myelofibrosis falls under. So, they're related to MDS in that they're both what we call myeloid conditions, but it's sort of a different family of diseases from MDS.
Thank you. Yeah, a few more questions that just came in here. Would the newer treatments for low-risk MDS be useful for people not yet dependent on transfusions?
Yeah, so that's a really good question, and I think that's an answer that we're still waiting for from a lot of these clinical trials. The majority of the trials for new treatments for lower risk MDS are usually looking at eliminating the need for blood transfusions as the kind of endpoint. And so I expect for the most part, those treatments will really be directed towards people who are needing blood transfusions. But I think that, that's something that we still kind of need to have answered in the clinical trials. But I'd say most likely it'll be primarily directed towards people needing blood transfusions.
Thank you. So I have a question mixed in with a comment. So thank you very much for a good presentation. What is the percentage of response following a stem cell transplant, like long-term remission? Also, where is the precision medicine project being deployed?
Yeah. So, in terms of the long-term, remission rate from stem cell transplant, kind of as I mentioned, it'll be individualized depending on a lot of factors. Some of those factors include what kind of conditioning you get, what the genetics of your MDS are, as well as whether, what kind of a response your MDS has had to some therapies if you received any before. But kind of ballpark, usually it's in the 50 to 60% range typically. just on average, but it'll be slightly different for everyone. In terms of where the precision medicine project will be deployed, initially we're doing the investigations in Vancouver right now, and depending on what the results are of some of our initial investigations, I'd like to see it potentially rolled out across Canada. But really we're starting all of our initial investigations still in Vancouver, just because that's where all of the work's been done so far.
Thank you. I got about 3 more questions. So do any of the treatments consider reducing GBHD?
Yeah, so that's an important question for people who are getting a stem cell transplant. So, typically not, the treatments you receive before your transplant normally will not impact too much your risk of GVHD afterwards. But there's a lot of treatments and some new treatments that we have for people who do get GVHD afterwards. So as you might be aware, for people who do get, and just, when we say GVHD, that it means graft versus host disease. And that's basically when, after a stem cell transplant, this new immune system can recognize your own cells and cause problems like rashes or diarrhea or other symptoms. And so, the MDS treatments don't necessarily influence the GVHD risk, but there are some new treatments for GVHD that are coming out. The mainstay of the GVHD treatment is still steroids, which are things like prednisone. So those are still very important treatments, but we're seeing some new ones. In particular, that medication called ruxolitinib has actually shown some good efficacy in GVHD. So we have some new treatments there as well. But for the most part, steroids are still the mainstay of therapy.
Thank you. So I do have 2 last questions, and they're both asking for maybe some clarifications on some topics that you spoke about. Why do HMAs quit working after a while? I think just maybe a little bit more elaboration on that.
Yeah. So that's a really good question, and that's actually one of the questions we're trying to answer with this precision medicine project. The simplest answer is we really don't completely understand why. There's a lot of thoughts in terms of the reason, and the main thing that we think is that the HMA treatments are able to get rid of most of the MDS cells. But as I mentioned, there's always these kind of what we call the cancer stem cells that are still there in the bone marrow. So we think that while the hypomethylating agents are good at getting rid of most of the MDS cells, there's still a couple of these kind of cancer stem cells that are still there in the bone marrow. And the problem is that if you don't get rid of all of those stem cells, eventually they'll figure out a way to become resistant to the treatment and come back. How they do that in terms of how do they figure out how to become resistant, that's still a very active area of investigation. That's one of the questions we're hoping to answer with this project. So.
Thank you so much. And I think this might be the last question. I haven't seen any more come in. Can you explain more on the genetic factors with MDS? Also, thank you for the webinar. It was great information.
Yeah, for sure. So the genetic factors of MDS, there's a lot that goes into that. That could be a whole presentation unto itself. So there's a lot to know there. But the main things are that there's a couple of different kind of categories of genes that get mutated. And one of the gene categories that's very important is something that we call the epigenetic genes. And so what epigenetics is, it's basically the regulation of the genes. And that's when modifications are made to the DNA, things like what we call methylation and other things. And one of the most common mutations we see are in the genes that maintain this. So that's why we think changes to gene regulation, like changes to methylation, are a major factor in the development of MDS, because we know that the regulators of that are one of the most commonly mutated genes. There's other genes that get mutated in terms of genes that normally kind of stop cells from growing, and they kind of regulate the cell growth. Sometimes these get mutated, which sort of, you can think of it kind of takes the brakes off and lets the cells grow faster than they should. That's kind of one other category. And then one of the other big categories is something that what we call RNA splicing. And so what that is when the DNA is turned into RNA in the cells, there's kind of this recombination of these RNAs, and sometimes errors in that can also lead to MDS. So those are kind of the 3 broad categories, but there's a lot of detailed information in there as well. So.
I did get one question, actually. I'd really like to ask this. Does it matter that family history of cancer was not blood cancer related?
Yeah, so that's a really important question. And, you know, as the kind of inherited predispositions to these cancers is something that we're really starting to understand, and it's quite new information. But that said, we do think that there's, you know, even non-blood cancers, if people have a strong family history of those, they definitely can be related. You know, because there are certain mutations in the gene that can lead to both blood and other type of cancers. So it is potentially relevant, you know. But there's a lot of other things to consider, as well as how many people have had cancers, you know, do they have other risk factors for cancer, right? You know, like smoking and things like that. But that said, it can be related sometimes, yes.
Excellent, thank you very much. I don't see any further questions. And, you know, if any of them do come in moving forward, we will do our best to answer those offline. So in the meantime, Dr. Stubbins, if you don't mind changing the slide, I'd just like to remind everyone some important information. So please remember that we are here to help you. So do not hesitate to contact the LLSC if you need more information or if you need support. You can reach us by email at info@bloodcancers.ca, or you can call toll free at 1-833-222-4884. Also, make sure to check our website regularly to watch all the past webcasts or for the dates of our upcoming webcasts. A final note as well is please realize that there will be a short survey that will be sent to all participants after the webcast. It would be really greatly appreciated if you can take a moment to fill it in, as it really helps us to offer you the most valuable information in the near future. So Dr. Stubbins, thank you so much for being here today. It was really, really fantastic presentation, and we look forward to hearing some more about this.
And thank you very much for the opportunity. And thanks everyone for attending.
Thank you so much. So thank you everyone for joining us. Have a wonderful day and stay safe.